Once again, good evening to you all. Am I audible and my slide is visible?
Yes, you are audible and your slide is visible.
Okay, thank you. So once again, good evening. So today, as like Sister Sheba told, we're going to discuss about the wound management. We are all health professionals. We are all know about the wounds and what are all the type of the wounds and how we can manage the wounds. Everything already we know. Not a new topic for us all. But basically in palliative care, mainly two type of the wound is majority in times we are all seeing in patient side, we are all handling, or maybe these two types of wound becoming on challenging type of wound in basically palliative care. That's why we're going to discuss about two type of wounds here. So as like we know, wound means a continuity of the skin of our whole body is losing because of any accidental injury or maybe because of any surgical procedure. So the type of wound it will vary as like that, surgical wound or accidental injury, burns like that. But here actually we going to discuss about two type of wound. So our main learning objective at the end of this session, the participants need to can identify various type of wound basically seen in palliative care. In one type of wound having some stages, so they can explain about the stages and the nursing intervention in appropriate stages. Then how they can apply the comfort focused wound management, basic principle in palliative care, comfort centered care. Then can recognize psychological distress relating to one of the type of the wound, the fungating wound. Then can provide compassionate, dignity based holistic care for the patients. So we can move. Already I told two type of wound, pressure sore or pressure injury and the fungating wound. So first of all, we can discuss about the pressure injury. The initial name was pressure sore, but now we calling it as a pressure injury. Why? Because pressure injury is as like an accidental injury. Because this is a preventable thing. We can prevent, but in somehow it's developing because of some of the reasons. So this is we calling it as a pressure injury. We can define as it's a localized injury happening on the patient's body, basically bony prominence areas or pressure prone areas because of the unrelieved pressure getting on that particular area for a long time. So this is the pressure injury. So simple pathophysiology we can generate. In this picture, you can see in supine position, one patient is lying for a long term. We can consider as a bedbound patient. So then how we can develop the pathophysiology? First of all, this patient is lying in a supine position. So the actual body weight, we can consider their bone weight as the body weight. Then the covering, soft tissues, muscle layers, skin layers, and everything. We can consider as the soft tissue parts. So if that in that stage, patient is lying in the supine position, the bone weight, that body weight is compressing downward on the mattress. In between, this tissues, muscles, and this skin layers is getting compression in between. So pressure for a long time. In between the underlying blood vessels, small and large blood vessels collapsing. Because of that, adequate blood supply is not at all getting to the tissues and cells. So inadequate blood supply, adequate nutrition and oxygen is nothing is getting or it's in less in. So because of that, tissue becoming ischemic or hypoxic. At last, the skin it will getting stressed and breakdown of the skin. Then this type of pressure injury is developing. So what are all the actually the risk factors? Risk factors means so many risk factors are there. Generally, some maybe you are telling bedbound patient. Bedbound patient means also some more risk factors also there. First of all, generally we can call it as a poor nursing care aspect, the friction. friction is a poor nursing care aspect thing only, because as like we know what is a friction in opposite direction on surface is moving, in between on force is developing. So in clinically how I already told poor nursing care. How it's happening means, if one patient is lying in a supine position, we need to uplift the patient the head end. Suppose the nurse or the caregiver trying to pull the bed sheet for lifting the patient. In that time, if the patient is heavy, means patient remains on the same stage, and under his or her body, the bed sheet is moving forward or backward. So in that time, because of the friction, the skin peeling chance is very high. Another one is the shear. Shear actually very most similar to the friction. Here actually one example I can tell, if the patient is suffering because of the breathing difficulty, or maybe we planning for the rice tube feeding, we just elevating the head end. We making semi-Fowler's or Fowler's position. At that time, for a long time, if the patient is being in that position means, in downward, the patient knees are bent, and accidentally it's moving downward. At that time, actually, the patient's upper body in elevated stage. So the upper body weight completely compressing their ischial area on the buttocks. Then plus patient is moving. So the on compression force plus the moving. So it's a shear type of force is happening. This is also a reason for the in stage I will explain that all those things. One type of wound pressure sore is developing because of the shear force. Another one, if the patient is having birth itself having some defect, means handicapped or differently abled, we calling it as a differently able, that disabled type of person, or once the spinal cord injuries happen, patient becoming paraplegic stage, or patient is becoming unconscious or altered conscious level patient. These category patients actually they don't know because of the sensory perception. They are having no sense in particular part. So they are not knowing this part is not at all moving, being in on stage for a long term. Or patient is having no conscious, so patient is becoming in a vegetative state or becoming in a same stage for a long time. In these times, actually have the need of an assistance to get a position changing, or in sideline position or another position changing, on assistance is truly needed actually. So these type of types actually it's we can call it as some of the risk factors. In more, some risk factors also there: continuous fecal and urinary incontinence, and on that pooling patient is being geriatric population, or maybe same state of patient is continuously wetting in because of this fecal and urinary incontinence. Then proper nutritious food and hydration is not at all getting. Maybe patient is not taking or maybe not getting. So that malnutrition and dehydration is affecting their skin health. Then excessive body heat, continuously sweating, that one of the risk factor. Another one is the advanced age. Or we can call it as a geriatric population. Old age people, their skin is very thin, very most chance for getting peel. So these are all the some of the risk factors we can see. What are all the common sites of the pressure ulcer? In this picture, you can see red marked portions are all, we can call it as a bony prominence area or more pressure prone areas in various positions. First one in supine position. Supine position. Second one is the lateral position, either left or right, lateral position. Then semi-Fowler position or head and elevated state. Then wheelchair bound or chair bound person. These are all the category positions people actually we are all taking care, basically in palliative care. These type of person, these red marked portions are all the pressure prone areas. So in wheelchair bound means after the spinal cord injury, if once the patient is becoming paraplegic stage, so after the rehabilitation, we can make them to shift from the bed to wheelchair and the wheelchair to the bed. So maybe the patient is might be the breadwinner of the family, but accidentally this patient is becoming paraplegic. So another family member needed to go for becoming a breadwinner. So at that time, maybe in daytime, 8 to 9 hours, patient is becoming in the wheelchair stage. So in this wheelchair bound stage means also it's a risk factor. Those points already it's marked in the diagram. So these are all the areas having the more pressure prone points. So these are all the some of the real pictures in pressure sore might be are all seen. So these are all the same thing in various positions: supine position, sideline position, or lateral position, right or left. Then Fowler's position, then prone position. In these positions, these red marked areas are all the pressure prone areas. We need to assess, we need to more concentrate all these points while we seeing this type of bed bound or dependent type of patients. So stages of wound. My question is, how many stages are there in the pressure sore? Pressure sore actually having some stages are there. How many stages are there? Any idea? Some answers got us 4, 3. Okay, thank you for your responses. Actually, initially we are all telling us like 4 stages of wound. Actually, this pressure sore, it's a developmental phase type of wound actually. Initially, the wound is developing superficially. Gradually, in depth, it's affecting. So, according to the in depth how the wound is developing or how much in depth patient the wound is progressing, like that progression wise, actually, we initially we telling us a 4 stage, but later on we added 2 more stages. We can discuss. Uh, First one, stage 1. Stage 1 actually we can call it as a non-blanchable erythema or the skin not at all lost but some color change is there. So maybe pinkish color or brownish or reddish color type of color changes only. Already I told which are all the bony prominence or pressure prone areas. All those areas having some color change. Only no skin peeling. This is the stage 1. Stage 2 is a partial thickness of loosening of skin. Means this type of. Means only the superficial skin, only it's lost, no in-depth it's affected, plus blister formation also we can consider as a stage 2. Because in this blister formation, serous fluids collection only is there, but we can expect it will open and it will may become as like a partial thickness skin loss. So we can consider these two as a stage 2 pressure injury. This one is the stage 3, full thickness ulcer. We can call it as completely it's affected full thickness ulcer, but it not at all visible by the bone and muscles or tendon. Nothing is visible, but some more in depth it's affected. Maybe slough maybe will be there or granulated tissue. Both are we can expect in stage 3. Plus tunneling type of wound also we are considering in the stage 3. Tunneling means actually the diameter maybe it's very less. It's a small wound but in various clockwise direction, maybe various clockwise direction or at least one clockwise direction, some extension is there. So it's a tunneling. This tunneling type of wound also we considering as the stage 3. So this one is the stage 4. Stage 4 actually muscle, bone, tendon, everything is exposed, maybe highly infectious, pus discharge, maybe foul smell. That type of in that much in-depth wound is the stage 4. It's a bone up to the bone completely is visible. This is a stage 4. Actually, initially up to the stage 4 was there, but gradually we added one more stage. It's a unstageable. We can number wise we can call it as a stage 5. It's a unstageable. In this unstageable wound, you can see two pictures. Two pictures actually seeing one thing, Eshkar. It's a blackish slough, calling it as a Eshkar formation. This Eshkar is covering on the wound. So actually the wound may be stage 3 or stage 4. But we don't know because this Eshkar is covering. It's actually hiding the wound inside. So we calling it as a unstageable. First picture you can see this also Eshkar, but this Eshkar having one difference, it's a dried form only. Majority of the geriatric population, old age people, actually this type of Eshkar we can see. While we seeing, we can, if we are tapping on the Eshkar means as like a dried, very dried band type of sound we can hear. This is the first type Eshkar. This Eshkar we are considering as the protective layer because there is a no discharge is there, no infection sign is there. We are considering their age factor, say very much in geriatric population, no need to do the further management and make pain for them. So we are considering this type of Eshkar as the protective layer. Second one is not like that. It's very wet form. It's very infectious sign is there. We needed to remove the Eshkar and we need to do the management accordingly. So these are the two type of Eshkar covering unstageable wound. Management we can discuss later. So another one, again sixth, another one more injury, pressure injury is recently we added deep tissue pressure injury. Number wise we calling it as a stage 6. It's a one difference. This and stage 1 both are non-blanchable, but in depth up to the stage 3 or stage 4 type of tissues affected already, but the superficially skin is not at all lost. This is the difference. So this actually, this pressure injury, stage 6 deep tissue injury is causing because of the second risk factor, shear. Already I told on compression force plus moving. That compression because of that only up to the tissues as like stage 3 or stage 4, that much up to that the tissues affected but the superficial skin not at all lost. This is the deep tissue pressure injury. While we seeing this type of bed-bound and dependent or this type of patient, we need to assess their pressure-prone areas. Then, if once the wound is developed, means first of all, we are concentrating the comfort based, so we need to address their pain. If any pain is there or not, we need to assess. Then wound location we need to note. Then wound measurement is also very, very important. Circumference, the in-depth and everything we need to note. Stage of the wound. Then any exudate, any secretion is from their wound is there or not. Its color, any foul smell is there or not, quantity, everything we need to know. Then tunneling means multi-tunneling is there or not, or unit tunneling. We need to mark it as a clockwise direction. Which clockwise direction actually the tunneling is there. Everything, every finding we need to chart. Management. First of all, again I am repeating, pain is the first of all thing. We need to give or we need to medicate the patient for the pain, manage the pain. Then we need to move for the wound care and wound management. So first of all, stage 1. Stage 1 actually I told there is a no wound developed, only the warning sign, color changes only is there. So excellent management, the position changing. Every second hourly need to change the position of the patient from supine to lateral, lateral to supine, supine to another opposite direction of the lateral, like that. In between need to change the position. Then incontinence, both bowel and bladder incontinence we need to manage. Stage 2 actually just the superficial skin only is lost. Clean with the normal saline and dressing we can do. Only the normal saline cleaning and we can apply the Biolin or the liquid paraffin, it's only needed because actually the natural wound healing we need to promote. For that, the one moisturizing medium only we need to maintain on that. Because of that, I'm telling biolin or liquid paraffin only it's actually needed. But if any antibacterial effect is needed, any ointment is needed means also we can apply for a short period tea bag, mupirocin contained ointment we can suggest. Otherwise, only the biolin and liquid paraffin is needed. Then stage 3, 4 and 5. In both from the stage 3 actually the slough formation we can expect. So first of all I am telling about the stage 3 and stage 4. In stage 3 and stage 4, suppose the slough is there means any surgical debridement option is there or needed means we can facilitate, or otherwise we can clean with the normal saline or homemade saline preparation. I will tell this. By using the normal saline we can clean the wound and we can apply debridase ointment on the slough area. In stage 3 or stage 4 I am telling debridase ointment or papain urea contained ointment. This is not only the debridase, that type of content medication we can use, because once the surgical debridement is possible and needed means we will do. But if it not possible or patient is not willing or patient condition is not in that stage to shifting to the hospital and do the management, then we can depend on the chemical debridement method. So chemical debridement method, I am telling about the papain urea contained ointment, debridase ointment for the slough formed areas only. Then good granulated tissue area surrounding granulated tissue area if having means we can apply the nano silver colloid content ointments like mega heal type of ointments we can apply. So according to the, if slough means we can apply debridase. If the good granulated tissue means we can apply the mega heal and we can do the dressing in both 3 and 4. Suppose 5 means unstageable. It's having thick eschar black slough is there. On that papain urea, it's not at all, it will not act. So we need to remove the slough or this eschar. So for removing eschar, again I am telling, if the surgical management is possible or needed means we can, or otherwise in our setting also majority of the rural type of patient not at all willing because of their family scenario, they are not at all willing for the surgical wound debridement to the hospital. So actually we can make as a thick biolin dressing. Thick biolin we will apply on the eschar and BD basis dressing we will do. After 2 to 3 dressing, this thick eschar it will loosen. Easily we can cut it from the wound. Then we can again move to the debridase on the slough, and after getting the granulated tissue, we can move to the mega heal ointment also. These are all the management for the stage 3, 4 and 5 for the slough, eschar and good granular tissue management. Along with that, one more issue, exudate and the foul smell. If the wound having the foul smell from stage 3, 4 or 5, any wound having the foul smell means we can apply metronidazole, tab metrogel powder, crushed form. We can mix it in the biolin or liquid paraffin and we can apply this jelly paste form of metrogel on the wound after the wound cleaning. This we can do for a short period. This metrogel we not at all using for the wound healing, only for the wound foul smell management. That thing we need to keep in mind. No use in the wound healing. So for a short period we actually doing. In addition to that, along with the metronidazole powder or avoid the metronidazole powder, we can use the metrogel, metronidazole injection form also, that drip type of medicine. We can use it for wound irrigation. After cleaning with the normal saline, we can irrigate the wound with the metrogel solution. In addition to that, if suppose tunneling or some gaps are there inside the wound, means we can nebulize by the metronidazole solution also. Take the nebulization kit, remove the mask. Inside the nebulization chamber, we can pour 3 to 4 ml of metronidazole solution. then we can switch on the nebulizer. This fume, it will easily enter, every gaps and pocket formation of the wound. So it's very helpful for controlling the odor. This 3 to 4 ml actually not a dose form, it's a quantity. It's for 10 to 15 minutes we need to give the fumes to the wound. For the volume only 3 to 4 ml, not as per the dose basis. So this malodor, in addition to that, we have another option also, charcoal pieces. We can place this charcoal pieces inside the room actually. Under the patient bed, we can place it. This charcoal actually act as antioxidant. It will absorb the foul smell from the wound. We can use it like that. Then if any surgery consultation is needed means we can facilitate or otherwise we can do the management already as like already I explained. In addition to that, and at any point, as per the plastic surgeon's opinion, negative pressure wound therapy. It's an option. Is if it needed means we can do by using this type of equipment. Not at all needed this type of equipment. By using our normal suction apparatus also we can do, but truly do under the advice of the plastic surgeon, not directly. So these are all the some wound dressing, traditional wound dressing pads only now also we following, and common people also can manage this type of traditional gauze cotton composition dressing pads. Other things also it's available. I am just making to aware you all. So films, foams, hydrogel, hydrocolloid, bioactive. These are all the some of the costly modified type of dressing pad. If any patient is affordable, if they are wished means we can suggest these type of dressing pads, or otherwise for poor people actually this traditional type of own dressing pad we can suggest. This foam type actually we can use it for the stage 1. It's act as a cushion like effect on the area because there is no skin peeling. So color changed part we can apply the foam type of pad means it act as a cushion effect. So further pressure it will not directly get on that area. Then hydrocolloid and other dressing pad actually having highly absorbable capacity and highly sealant ability also. So there is nothing, it will leak out, exudate. I'm telling about the exudate or secretion, it will not come out. So in addition to that, no foul smell, it will come outside. Then highly absorbable also. Actually, this hydrocolloidal, all those dressing, we can use only for the wound that not at all needed daily dressing. Means once in 2 days or once in 3 days, frequently changing dressing only, we can use this type of hydrocolloids. So homemade saline, actually we telling 500 ml of water, 1 teaspoon of salt, we can add it, mix it well and boil it well. After boiling, we can make it as cool and store in a clean container. They can use the solution for the wound cleaning. So as like normal saline, homely, we can make this type of solution for the wound cleaning. Protein iodine, betadine, or hydrogen peroxide, nothing we can use it for the wound dressing because it will not help the wound healing or the benefit of the wound. It will again worsen the wound because it will lose the granulated tissues also. That thing we need to keep in mind. In addition to that, I already told this type of traditional dressing pads we are all using in our hospital. In home setting also, in our days recently, in every palliative care center, in government setting also, they are all providing cotton rolls and this type of gauze clothes for the dressing pad preparation. They are all getting. So if we are getting the material means we can educate them to how to prepare by using this cotton material and the gauze colloid, how they can prepare. We can educate them. If suppose in rural areas or some tribal areas, that much in that much remote areas, if they are not at all getting this type of dressing material means they can use clean cotton cloth material, dhoti or lungi, that type of material. They can cut, make it as a pieces, and they can use that thing also for the wound dressing. But after both, after the preparation, they can steam in idli cooker. They can steam it and they can keep it in a clean container. They can use this pads for the wound dressing. All those practices we can educate to the caregivers also. So I already told pressure sore. Now it's a pressure injury. We can prevent. So how we can prevent the bed sore or pressure sore? So first of all, position change. Every second hourly need to change the position for the bedbound patient or the paraplegic type patient also need to change the position every second hourly in lying time. But if once the patient is becoming in the wheelchair or chair-bound patient means it's a part truly the part of the rehabilitation. Physiotherapists actually training them. They can just hold their both hand on the handrest of the wheelchair or the chair. Then they can completely lift. They can full body. They can count the number 1 to 10 seconds. They can count internally. Then they can hold and lift their complete body on the air by using their both hand. So it's a truly needed hand holding capacity, hand strength, and balancing everything. They need to train. After achieving that, only they can do. So every 15 to 20 minutes, they can lift their complete body on the air. So in that time, that pressure prone areas are all getting rest during that period. So they can prevent the bed sore. In addition to that, both bowel and bladder incontinence, it's very important. Then special surfaces like air bed or alpha bed or water mattress. We are also promoting air mattress or the alpha bed. This type of mattress they can use it. But we need to convey the point. This is not a preventable thing. It's a comfortable device only. Even if they are all lying, making the patient lying on the air bed or maybe in the normal bed, need to change the position every second hourly. So this is a less risk factor device only, not at all preventable thing. So that thing we need to convey, or otherwise they will think this alphabets once they are getting, they are making the patient on lying on the alphabet means this is the solution for prevention of bed sore. Not like that. Position change is very much important. That thing we need to convey. Then on position changing, various areas need to get the support by using pillows and cushions. That thing we need to convey. Which are all the areas need the support. Then proper nutrition, hydration, and at least minimum range of motion exercise also very much important. That thing we need to convey. Here actually exercise not at all for making them to wake up and do the activity roam in around, not like that. Movable joints need to move. At least we need to prevent the contracture and all those things. So minimum range of motion exercise at least we need to do. Actively if they are able means they can do. Passively if needed means that body parts caregiver can do. That thing we need to train. Then as a part of the skin care or back care, we can do the massage by using liquid paraffin or white petroleum jelly. Very, very important last point, wrinkle-free bed. If we making the bed for the patient means truly wrinkle-free bed we need to give, or otherwise wrinkled bed on that if the patient is lying means second risk factor. Again, the shear type of pressure injury chance is very high. In addition to that, nail care, actually sharp nail is a chance for injury getting for geriatric population, or maybe example in lymphedema. Lymphedema patient also, once the patient is getting, condition is deteriorating, patient is continuously in bedbound stage. Same time, the nail care also very, very important that stage also. Not only for the bedbound, lymphedema, especially the nail care is very much important. I just collaborated both it like that. That thing we need to convey. So this prevention method technique, we can short form, we can call it as a SSKIN. First S is the supporting surface as like alpha bed or water bed. Skin inspection as a part of assessment. Every bony prominence area, pressure prone areas we need to assess. Then keep moving, position changing every second hourly or every 15 to 20 minutes for the wheelchair patient. Both bladder and bowel incontinence, and we need to do the moisture control. Then proper nutrition and hydration is very much important. These are all the preventive technique for the pressure sore development. So we need to keep in mind and we need to do the activity this point, we need to engage the patient and family also. This prevention method, truly we can succeed by the term we. Not only from health professional side, or not only from the caregiver side, or not only from the patient side, we can achieve. So together, health professional, we are all making training, we are making educating the caregiver. Caregiver need to have the mindset to implement all those things for the patient, and patient also need to cooperate. So together only we can achieve the prevention of pressure sore. That thing we need to convey. So for that purpose, after getting the caregiver education, we can give this type of leaflet. Actually, this leaflet we prepared and we are all using in our setting. It's in a Malayalam language. In your mother tongue also, like this type of leaflet, you can use it. So after prevention method, that position changing every second hourly, position changing, which are all the areas needed the support of pillows and cushion. All those things in this diagram it's have. So this is this leaflet actually will help them as a reminder. So these are all in the pressure zone. So second one, part 2, second one is the fungating wound. So here actually having one change, pressure sore, we had some option for prevention. In fungating wound or cancer wound, having no option for the prevention. Pressure sore, we have so much management for getting healed. But cancer wound, majority of the cases, having no option for getting healed. So we calling the cancer wound as a non-healing ulcer there is no chance for getting healed, this type of cancer wound. Cancer wound actually we calling it as a fungating wound also. Why we calling it as a fungating wound? Any connection with us like fungal infection or any fungal involvement or any fungal infection, any history? Nothing. So it's a looks like it because of the shape. It's a nodular fungus model or as like a very sorry cauliflower like shape type of nodular wound, massive wound. Because of that appearance only we calling it as a fungating wound or the cancerous wound. So definition, it's a primary or secondary based malignant growth or nodular growth happening on the skin, which gradually it's ulcerated and difficult to heal. So this having also small pathophysiology, we can make it as like this development of a small nodule on the skin or on the tissue. Then gradually the nodules becoming enlarged. Because of the enlargement of the nodule, underlying capillaries and lymph vessels becoming compressed and the blood circulation, it will vary in between bleeding or in between clot formation. So disorganized circulation through those capillaries. Because of that also the tissue becoming hypoxic and necrotic at last. Because of the stress, the skin it will open and this nodule becoming on the fungating type of cancerous wound. This one is the pathophysiology. Another one is the Marjolin's ulcer. Actually, Marjolin's ulcer is not another type. Actually, Marjolin's ulcer is one of the malignancy, condition of the malignancy inside the same chronic wound. Example, burn scar, pressure ulcer, or venous leg ulcer. Chronic prolonged wound already having some malignant changes. This also having one pathophysiology. Normally, the wound maybe had no pain, no bleeding, no specially exudate, nothing. But recently having some pain, maybe night or during the dressing time, some pricking or burning type of pain, or maybe the secretion level is increased. That much pad is dressing pad is wetting much, or maybe foul smell. Like that, some changes it will happen, or the wound bed looks like some difference, some in between growth and gutter type of appearance on the wound. At that time, in doubt, if suppose we are doing the biopsy means, at last we can conclude it as a Marjolin ulcer. So both Marjolin ulcer and the fungating wound, we can consider, or we can see some of the problems. Every palliative care symptom, we in every aspect, both physical, psychological, social, spiritual, every aspect have the problem. But basically inside the wound, this fungating type of wound, we need to focus every aspect. It's a very, very important. First one, physical. In physical, actually, we know a cancer wound means very much painful. Pain will be there. Foul smell, malodor should be there. Bleeding, and sweating type of bleeding, or gradually profused, maybe us like emergency, that type of profused bleeding. The chance is very high. Then exudate. Day by day, the quantity, color, and everything, it will increase. Frequency of dressing, pad changes we need to increase. It's natural. Then itching on the wound and in around the wound, the nearby skin area also, the itching chance is very high. Then if the wound is not at all handling in hygienic manner, maggots infestation is very high. Chance is very high. Then suppose the wound on, example, see a buccal mucosa. This type of fungating wound on the cheek and on the floor of mouth and everything is there means communication difficulty. Surely it will be there. These are all the some of the physical problem. In addition to that, as a nurse or as a doctor, we are all focusing on the physical distress, but along with that, as an empathetic approach for making comfort for the patient, we need to focus other regions also. So we need to look the psychological altered body image. Their body image, it's altered, looks very different. So along with that, their sexual life is affecting, having fear, they're having no acceptance power. Because suppose today the wound is bleeding, surely they are having the fear. Tomorrow, how will be my wound? What are all the things will happen? If it needed to shift to the hospital, after moving to the hospital, what are all the process is needed? Or maybe because of the bleeding, may I am going to die? All this type of fear, it should be there. Along with that, depression and anxiety will be there. Feeling of shame, ashamed of because of the wound for facing to another one. Then feeling of guilt. Example, one, if the same person had the practice of using tobacco substance, surely they are having the guilt as like, because of my practice only this wound is developed, because of my fault this has happened. So that feeling also, it's a very much painful psychological basis. In addition to that, social actually, family isolation, not only the family isolation, self-isolation already started from his or her side. Along with that, family becoming isolated, social isolation is very high. Maybe the same family having small children, they are all having the practice to go nearby house and playing with them, or otherwise nearby home, their children is coming to this home. That practices everything, it will stop because of this type of isolation. Then on occasion, marriage or any other occasion happening in our house or maybe in our relative's house, not at all willing to move to there, or they are all not willing to invite us also. That type of things, chance is very high. Then fear, social stigma, it's very high. Then effect on family, truly affecting on the family, truly affecting on their sexual relationship and their marital relation, it will affect. Spiritually, it will truly interfere their religious rights. Actually, spirituality, we know in the spirituality, religion is only one component, not the main. But if for the person, spiritual, religious belief and rights and their cultural customs, these are all their main factor in the spiritual aspect, means it's a truly affecting thing only. So if one person having the practice of in early morning they are going to the temple, but after this type of wound, they are all not willing for go to the temple or can't go to the temple. Or in addition to that, they will feel this is the punishment I'm getting from the God. Or then at last they are maybe having the fear of impending their death also. Actually, two type death they are having because of the bleeding or pain like that, how my death will be. Or otherwise, some person they are thinking after the death, now only my wound is having this much foul smell. I am looking in this stage. So after my death, how my body, my family member will expose to the other people. How long they can keep in my body in open. So because of that, we are also some person is living. So because these all aspect patient is having, surely they are having the distress. So, as our part, first of all, we need to assess wound location, we need to assess wound appearance, any surrounding skin areas, we need to assess any bleeding or any other chance is there or not, we need to assess. Then, our principle of management, first of all, comfort based, their palliation. Symptom management is the first of all thing. So, prioritizing their symptom, first of all, pain. We need to reduce their pain. Then we need to control their foul smell or malodor, infection related or according to the wound progression, the odor we need to control. Then exudate, secretion we need to manage. Then bleeding, chance we need to prevent, or once the bleeding is happened means we need to manage. Maximum we need to minimize and we need to avoid the bleeding chance. So these are all the main principle of management. Along with that, holistic care, every aspect, physical, psychological, social, spiritual, every aspect we need to consider the patient, then we need to do the management. That's the holistic care, actually, we telling. Then we need to empower not only the wound care, empowering of the family members is also very much important. We need to empower. How we can empower? We can educate the caregiver about the wound dressing and what are all the warning signs we need to give about the wound, bleeding or any other thing. We need to convey to the patient. So our nursing intervention actually we focusing on the dignity centered of the patient. Dignity of the patient we need to consider. So we need to maintain privacy while doing the dressing. We use respectful communication with them. If they needed more time to convey their distress to us, so maximum we need to listen them. Maximum we need to avoid the negative facial expression on our face. So because while doing the dressing or while doing the communication, they will look our face. Any negative facial expression because of the foul smell or because of the appearance of the wound, any negative facial expression, suppose they are seeing in our face, means it will hurt. So that thing we need to keep in mind. Then malodor is a as like pain, malodor is a one of the psychologically affecting thing only. So regular dressing change is very important. Regular dressing means frequency we can't set for everyone. In some dressing, maybe not only by BD basis we can manage. Maybe 3 times, maybe 5 times. According to the exudate, quantity of the exudate and the type of the wound, we need to change the dressing pad. Then odor controlling agents, we will discuss later. Then proper waste disposal on time. On even soon after the dressing, wound dressing, the soiled dressing pad we need to dispose. No need to keep it in same room for a long time. Then emotional support. Emotional support actually active listening is the one of the main point. We need to listen. We need to acknowledge. We need to address their complete distress. Not only the pain, not only their foul smell, not only the bleeding. There are other aspect also. I already discussed about the psycho, social, spiritual. Every distress we need to address. Then if anything counseling is needed means at least it's needed means we can do other ways if not possible from my practice I'm not able means at least we need to facilitate them to the for the counseling. Then family education is very important, not only the wound care, every aspect. We need to do the wound care management. We can educate. Then our main aim reduce the stigma and fear about the wound. For that purpose, we need to talk to the family members. Then we need to explain about the malignant wound also. Actually, the difference we know. This wound is not at all going to heal. That thing we need to convey. Then only with the acceptance, family members in their own way, holistic manner, they can continue the care for the patient. Holistic approach, I already told, you need to address the spiritual concern, their quality of life, how we can improve the quality of life. That aspect, not only the physical, in spiritual aspect, other aspect also, how we can improve the quality of life or how we can maintain the quality of the life of the patient. For that purpose, in that center, we need to do the management. Then again, we are coming back to the physical aspect, criteria for the wound management. Empathetic care, I already told. First of all, for preventing the bleeding or for preventing the pain, first of all, we telling this type of fungating wound patient, before removing the dressing pad, old dressing pad from the wound, thoroughly we need to wet. If it possible means they can take a nice bath. After the bath, the pad will be very much wet form. We can easily remove from the wound. So they can take a thorough bath before the dressing. Our main aim to maintain or improve the quality of life of the patient through the symptom control only. So because of that, actually, first of all, we focusing on the pain because we need to improve the life of the quality of life of the patient. So here, first of all, while we discussing about the pain, we are all know so many type of wounds, pains are there. So basically, neuropathic or nociceptive type of pain, this type of patient might be experiencing. Nociceptive pain means already having aching, stabbing type of continuous pain will be there. For that purpose, maybe systemic analgesic, as like opioid, any medicine suppose already getting. Means before dressing, we need to ensure this pain medicine already the patient is got. Or otherwise, we need to give the medicine, control the pain, then only we can start the wound dressing. If once the neuropathic pain, suppose burning or pricking type of pain is reporting, means local application of lignocaine or bupivacaine, we can use it. In our setting, actually, we using injection bupivacaine. Injection bupivacaine 0.25% and 0.5% is available. 0.25%, 0.25 means we are taking 6 ml of quantity of medicine plus 4 ml of distilled water. We are making it as a 10 ml quantity of medicine. 0.5% means 3 ml of medicine plus 7 ml of distilled water, make it as a 10 ml quantity of medicine. This dilution as per the 10 ml quantity of medicine. As per the wound size, we can reduce or we can increase this dilution. So actually, before 20 minutes of dressing, we are all spraying this bupivacaine on the wound. Then only we starting the wound dressing. After wound dressing also, again they are telling means again one more time we can spray this bupivacaine on the wound and we can close it by using dressing pad and medication. So here also malodor, it's a very important thing only we need to manage. So daily cleaning, frequent dressing, proper cleaning is very much important. Here also locally we can apply metronidazole, tablet form of medicine. We can crush, we can make it as a powder form. Then mix it in the liquid paraffin or biolin, make it as a jelly or paste form. Then we can apply on the wound. Or otherwise, we can here again same metronidazole solution, injection metronidazole, we can use it for the irrigation and the nebulizing. Because this type of fungating wound or cancerous wound, so many foldings will be there, pocket formation will be there. In between, blindly, we can't put the artery forceps and do the scrubbing and dressing. Because at any time, the bleeding chance is very, very high. So at that time, this metronidazole nebulization fumes, it will enter in every region and through that way we can control the foul smell. Here also metronidazole having no healing purpose, only the foul smell management only. Once the foul smell management is success means we can stop. Otherwise, we can continue. In addition to that, systemic antibiotics is any need is means we can start the systemic IV or oral antibiotic. We can start it along with that. Then frequent dressing changes. I already told according to the wound secretion, according to the wound, we can set the frequency. Maybe more than 3, 4, or 5 times, maybe daily. It's needed. If needed means we need to do. Otherwise, no. No hydrogen peroxide, beta-adine, iodine solution, nothing is needed for cleaning this type of wound. Only the normal saline or homemade saline only needed for cleaning the wound. So actually, in this wound, I already told this type of things we can use it for the foul smell control. Along with that, charcoal. Charcoal dressing pad is available in the pharmacy. We will get, but it's a little bit costly. So costly type of charcoal dressing pad we can't suggest for the poor patient. So for that purpose, in our setting, we implemented charcoal preparation by from our side. So for this charcoal preparation, we selected coconut shells. We burn it and make it as a charcoal pieces, and we crushed and we make it as a powdered form. Then this powdered form of charcoal, we mixing in the biolin or the liquid paraffin, making it as a paste form. This paste form we will apply on the dressing pad. Then we not at all placing this dressing pad directly on the wound. Already will clean application of ointment, packing with the normal dressing pad. On that extra dressing pad, this prepared dressing pad we will apply. Then we will see. Actually, here it's happened means from the wound itself, developing foul smell, it will absorb by this bedded charcoal paste form. That way, we can control the foul smell. This is another thing we implemented. We truly doing more than 1 year in our setting. So some new practices also I am mentioning here, but we not at all practice, but maybe in your knowledge, maybe will be there, or in your setting, if anything is there means take it as a refreshment. First one is the sugar paste. Mixing of the normal sugar in and in water, normal water, make it as a very much paste form, and we can apply this sugar paste on the wound. Actually, they are telling because of the high sugar content, the bacterial growth we can prevent, and through that way we can control this type of malodor or foul smell. Then yogurt or buttermilk application. Applying this buttermilk or yogurt means after cleaning, normal cleaning with the normal saline or the medicine, we can apply this yogurt or buttermilk on the wound for 10 to 15 minutes. After 10 to 15 minutes, we can wash it and clean it, complete this yogurt from the wound. So during this period, actually, because of the yogurt and buttermilk or curd presence, pH level, it will vary. Because of the unstable pH level, bacteria can't proliferate or can't grow, multiply. So because of that, we can control the foul smell. That practice also some places they are all doing. Another one is the medical grade honey. Honey actually highly osmolality environment, it will make it over there, and it inhibits, it will prevent the bacterial growth. So that way we can prevent, we can control the foul smell and the bacterial growth. So these are all the application. Another some odor concealers or aromatic therapy means actually some essential oils are available. Essential oil, I think you all know. Essential oil, some essential oils we are all using in the food also for cooking. But here I am suggesting peppermint or wintergreen, then lavender oil. These are all some of the essential oil. This oil we not at all directly applying on the wound. We will take this essential oil in a cotton ball and soak it well, and this cotton ball we placing on the head end or foot end of the patient bed only. So actually it's having not as like oud or other type of smell, but it's a natural thing. It will break the foul smell inside the room. So that type of aromatic therapy we can do. Another one is the before that bleeding, along with that Ayurvedic tuba type of means fumigation type of thing also we can do inside the patient room. It will also control the foul smell. Thubam karma, that type of Ayurvedic fumigation. Then another one, third one is the bleeding. Bleeding, I already told, for the prevention of the bleeding and for the both pain, how we can do the dressing. That thing already I told. Here actually somehow the bleeding is happening, sweating type of bleeding, anything is happening means we can apply local pressure over the wound area and we can manage the bleeding. Suppose the bleeding is high, means we can use the sucralfate powder. Nowadays, I don't know in your setting the sucralfate powder is getting or not, I don't know. In our setting, we are affecting some shortage. So we using ethamsulate tablet crushed form also we are using. Both sucralfate powder or ethamsulate tab crushed form. This powder, we can mix it again on the biolin or liquid paraffin. We can mix it very well. We can apply this paste form on the wound. It for a period only, not for continuous use. It also manage the bleeding. Along with that, tranexamic acid, then systemic ethamsulate for frequent BD or TDS frequent, IV or TAP, according to the scenario, we can use it. Along with that, for the maintaining or for improving the quality of life of the person aspect, bleeding control, any radiotherapy is needed. Only that point we can suggest the palliative radiotherapy also. Otherwise, leave it, no need. Then I already told we need to empower the patient family. So for that point, we need to make it ready dark colored clothes. In home setting means they need to keep it ready dark colored clothes nearby the patient side. In our hospital setting means also near this type of patient admitting nearby area, we need to keep it ready dark colored clothes. Because at any time, profuse the bleeding, the chance is very high. Or maybe because of the bleeding, the patient may will die. That's in that situation needed to handle by the staff or by the family members. So we need to empower the patient and family. Role of cancer therapy, if any role, I already told, for the improvement of the quality of life of the patient. In that aspect, any role for the radiotherapy, cytotoxic chemotherapy, hormonal therapy, anything, surgery, anything is needed means we need to do. Otherwise, no need to facilitate. We need to leave these points. Maggots, I already told the suffering, physical aspect. Final one is the poor hygienic handling of the wound, the maggots infestation. Prevention is very much important. For that purpose, maximum flies, mosquitoes, all these type of flies accumulating situation inside the room. Example, food, fruits, or even the soiled dressing pad. Nothing is need to keep it in the inside the room, or otherwise any wet environment. These are all the things we need to avoid, or otherwise spice it will be there. Then this spice once being on the wound means it will lay the eggs and the maggot formation is very high. Majority in our coastal areas or rural areas, aged people, they not at all covering their wounds. They are all maybe they are having misconception as like air circulation is needed for the better wound healing. So they are all keeping their wounds are all open. In that time also the maggot formation chance is very high. So proper hygienic wound the maggots prevention method we need to educate to the patient and the family. Once the maggots is formed means actually we can use it turpentine oil. Don't apply directly. We can soak it the turpentine oil on a gauze piece or cotton ball. Then we can just nearby the wound area we can place it. Because of this intensive smell, the maggots it will come out. Manually we can remove the maggots and put it in the hot water. Hot water also we make it ready nearby the patient. We need to count and we need to assess the size of the maggots also. maybe the more larva inside the wound is there or no, we don't know actually. The how we can manage the maggots, it's truly completed or not. So day by day, we need to count and we need to check the size of the maggots also. So these are all the maggots management from a normal wound area. But once the maggot infestation inside the cavity, means we can means example oral cavity or tracheostomy, or not tracheostomy, oral cavity or vaginally, rectally, that type of cavity region, any maggots infestation is happening means, if once the turpentine soaked thing we are showing means also inside that much lengthy tract is there, so maggots can hide along. So that time this turpentine with only the turpentine we can't manage. That situation we can apply vegetable oils, some vegetable oil, coconut oil, anything we can apply on the opening of the that area. So because of this oily closure, oxygen it will not enter. So because of lack of oxygen, maggots it will come out. At that time we can manually remove. These are all some management. So we need to do the preventive method, management also. These are all things. So with that, I'm finishing. Any doubt means you can ask it.
Surgeon sir, there is one question. Sir, sugar paste and yogurt are the approved one.
Actually, I already told this about the new practice. New practices in some setting they are doing. So we never practice, but a new as a new practice, 3 points I already just put for your discussion. Maybe in your sites, in various in your knowledge, if anywhere it's doing means okay. Otherwise, it's a discussion point only. We never practiced.
So there is one another question. Can you please share any evidence of charcoal dressing?
Charcoal dressing, actually, we never made it as a discussion material. In our practice, we truly doing since 1 year, more than 1 year, going to complete after starting this charcoal dressing. I already told this charcoal we not at all directly applying on the wound because it's a not as like from a purchasable thing only, that type of not at all that type of dressing pad is we only preparing. So normal dressing pad, on that only we applying this type of extra layer dressing pad.
Okay. Thank you, sir. There is one another question, sir. Keeping the charcoal under the bed for absorption for bad odor is a standard practice.
Yes, we can use in our setting also we are all using. We can use it. It's a two thing. Charcoal pieces, suppose I think everybody doing charcoal pieces we applying, we keeping inside the room. So inside the room only the foul smell is absorbing by the charcoal pieces. Here actually we trying to make from the wound itself the foul smells need to absorb by the charcoal bed. That thing we are trying to make.
പോയി നോക്കാനായിട്ട് ആ ചെക്കൻ എത്തൂലട്ടോ നോമ്പെടുക്കാന് ഷോൾ എത്തിക്കല്ലോ ഡ്രസ്സിന് ഒന്നൊന്ന് പോയി നോക്കാനായിട്ട് ലാസ്റ്റ് ആയിട്ട് അവിടെ ഇറങ്ങാൻ യാ
Is there any other doubts? Or else someone please share your feedback. How was the session?
Sergeant, please do now that your screen is visible, please. So, I hope the class is clear to everyone. Anybody have any doubts?
Some of them are already asked some doubts, ma'am. So I think there is no doubts more. So they are saying the session was clear and we learned many new practice.
Okay.
Thank you, sir.
Thank you. So if they don't have any doubts, we can wind up. Let me tell the next step. This is our phase 1 program. After this, we are going to move to the phase 2 program. Phase 2, we have around 40 participants. Each